Assalamu alaikum. This presentation is on a rare vocal fold lesion that can cause significant dysphonia, the vocal fold mucosal bridges. A vocal fold mucosal bridge is an epithelial strip that lies free over the vocal fold epithelium. It's attached only anteriorly and posteriorly, otherwise it's free and you can pass a blunt probe underneath it. It's like a band of mucosa that is longitudinally placed, usually parallel to the vocal fold edge. Histologically, the free mucosal bridge is formed of a core of connective tissue formed by the outer layer of the lamina propria, the rhynchus space. This is circumferentially covered by the stratified squamous epithelium. The vocal fold itself is also covered by stratified squamous epithelium that is almost always attached to the vocal ligament, the intermediate and the deep layers of the lamina propria. Resection of the mucosal bridge to correct the abnormality is not going to correct the dysphonia, as this would leave the indentation in the vocal fold and the glottal insufficiency, plus the stiffness of the vocal fold cover that is now attached directly to the vocal ligament. Mucosal bridges are different from glottic adhesions. Glottic adhesions form after trauma to the vocal folds or microtrauma during excessive phonation or voice misuse or abuse, or following inflammatory damage to the vocal fold epithelium. The damage is healed by fibrous scar tissue that can run in any direction, not necessarily parallel to the vocal fold edge as the mucosal bridge, and sometimes it can actually cross the glottal chink. The mucosal bridge is one member of a small group of vocal fold mucosal cover disorders that can have congenital origin due to maldevelopments in the fourth or sixth branchial arches during the laryngeal development. According to Boucher, there are certain facts to support the congenital origin of these group of mucosal cover disorders, including that the dysphonia in these disorders can start in childhood in more than half of the cases, that the lesions can be found in patients who had never had any voice misuse or abuse history or any significant laryngeal inflammation, and that these lesions, when completely removed, they don't recur back. These lesions can also be described to run in families, including vocal fold sulcus and epidermoid cysts. The association between the epidermoid cysts and the vocal sulcus and mucosal bridges occurs in about 15% of the cases. The other theory on the etiology of vocal fold mucosal bridge and these tiny group of mucosal cover disorders is that they are acquired following phonotrauma and occasionally laryngitis or upper respiratory tract inflammation. Secondary to these inflammatory or atrophic processes on the vocal folds, there may be some small breaks due to the phonotrauma in the overlying epithelium of the vocal fold and loss of a variable amount of the superficial part of the lamina propria. This can also happen following upper respiratory tract inflammation and atrophy of the vocalis muscle and the lamina propria. How can a mucosal bridge of the vocal fold develop? According to the congenital etiology theory, if a sulcus vocalis or an epidermoid cyst of the vocal fold has double punctures, then a small area of the isolated epithelium would lie free between the superior and the inferior puncture and form a mucosal bridge. The other theory of the acquired origin, the mucosal bridge would develop because of injuries, microtrauma to the mucosal cover of the vocal fold, because of misuse or abuse, or because of inflammation, and that would leave us an island of mucosal cover epithelium over the surface of the vocal fold true cover. Mucosal bridges are not common, but it may be underreported. The reason is likely attributed to the difficulty in the diagnosis without actually having a direct microlaryngoscopy under general anesthesia and palpation of the vocal folds with blunt instruments. Mucosal bridges of the glottis can be reported in as much as 30% of cases of sulcus vocalis and epidermoid cysts. The true incidence of the minor alterations in the mucosal cover of the vocal fold may be underestimated. In 1958, Arnold described this group of lesions as MSA, minimum structural alteration of the mucosal cover, just tiny lesions of the mucosal cover like sulcus vocalis, epidermoid cyst, mucosal bridge, or a laryngeal microweb, or even varicosity of the vocal folds itself. These tiny lesions can still interfere with the vibratory pattern of the mucosal wave and cause significant dysphonia. How common are these lesions? There was a study of patients who were examined under anesthesia by microlaryngoscopy to remove vocal fold polypi. In 1/4 of these patients, one or the other of these group could be identified. Half of the identified lesions would be sulcus vocalis, 1/4 would be a small epidermoid cyst, 1/8 would be a mucosal bridge, and rarely there will be either a microweb or a vocal fold varicosity. It's of interest to note that these tiny lesions were found by examination under anesthesia in the contralateral vocal fold to the side which had the vocal fold polyp. Mucosal bridges and the other member of the group of minor structural alterations of the epithelial cover are very difficult to diagnose, except perhaps under anesthesia with microlaryngoscopy and palpation of the vocal fold surface. But one way of suspecting the presence of this type of lesion is to look into the pattern of the superficial blood vessels over the vocal fold surfaces. If a patient has a mucosal bridge or a vocal fold sulcus, for example, then in about 90% of the cases there will be an abnormal pattern of blood vessels of the vocal folds. This is much higher than the control group, which have abnormalities in the blood vessels in about less than 1/3 of the patients, or even with polyps or nodules. One characteristic form of these abnormalities is the tangled blood vessel with frequent change of direction, and this is almost pathognomonic of a vocal fold sulcus or a vocal fold mucosal bridge. Other forms of abnormalities would be when a blood vessel is running transversely rather than longitudinally, or when there is an abrupt change in the caliber of the blood vessel, either abrupt narrowing or abrupt dilatation, forming an ectasia and dilatation of the blood vessel. How does patients with mucosal bridges present? They present with dysphonia. The degree and the severity of the dysphonia would depend very much on two things: the site and the size of the mucosal bridges. Mucosal bridges that are lateral rather than medial in site don't cause too much dysphonia, and mucosal bridges that are thin also don't cause too much dysphonia, but thicker mucosal bridges, particularly nearer to the medial edge of the vocal fold, can cause significant dysphonia. The dysphonia in the patients with mucosal bridges would be caused by impairment of the vocal fold mucosal vibration, the interruption in the mucosal wave. This would lead to voice fatigue and a voice that deteriorates rapidly. They would have higher pitches, they would have higher fundamental frequencies, and the voice would have a rough and a breathy component. The breathy component is due to the glottic insufficiency caused by the mucosal bridge. There will also be frequent fluctuations in the voice, frequent perturbations in fundamental frequency and the vocal intensity. Examination of the larynxes of patients with mucosal bridges may not show the lesion at all. Either the use of flexible laryngoscopy or direct laryngoscopy may not show the lesion. It may show an abnormal blood vessel pattern that would suggest the presence of a lesion. Stroboscopy could also suggest the presence of the lesion if there is a sudden reduction in the vibratory pattern over one area. The stiffness of this area would suggest either a vocal fold sulcus or a mucosal bridge, and only direct microlaryngoscopy under anesthesia with palpation could tell the difference between a mucosal bridge and a vocal fold sulcus. Stroboscopy here suggested the presence of two parallel vocal fold sulci, but only on direct examination with the microscope and with palpation that a mucosal bridge could be identified by passing a probe, a blunt probe, underneath the bridge. Careful examination of the vocal fold surface under anesthesia could show the presence of a mucosal bridge or a vocal fold sulcus associated with presence of other lesions on the vocal folds, like a vocal fold polyp in this case. The careful inspection in the area where there were some abnormal blood vessels showed a mucosal bridge plus the vocal fold polyp. The management of vocal fold mucosal bridges should focus on two things: restoration of the vocal fold mucosal wave and closing the glottal gap caused by the glottic insufficiency. A trial of voice therapy is always a good start, particularly when the symptoms are mild, but many patients will require surgery that has to be very precise in order to avoid any excessive mucosal resection or any excessive postoperative scarring or any injury to the vocal ligament. And postoperative voice therapy in all cases would be mandatory. The second focus is the glottic gap, and this can be sorted out after resection of the mucosal bridge by either fat injection or fat implantation, or using collagen rather than fat, or medialization procedures like type 1 thyroplasty. If surgery is indicated, microlaryngoscopy under anesthesia would be the best choice to resect only the undersurface of the mucosal bridge, not the whole of the mucosal bridge, just the epithelial cover of the undersurface of the mucosal bridge. Exposure of the bridge area can be improved by averting the medial edge of the vocal fold. Gentle pressure on a pledge placed laterally on the superior surface of the vocal fold would help in this aversion. And once a good exposure is achieved, the mucosal bridge is incised and only the undersurface epithelium is removed carefully, leaving the outer surface epithelium and the core of the connective tissue in sight, followed by removal of the epithelium overlying the vocal ligament of the vocal fold carefully so as not to injure the vocal fold ligament itself and not to cause any excessive scarring in the area. Once the two epithelial surfaces, the opposing surfaces, are removed, the remnant of the mucosal bridge with the outer cover and the core of the connective tissue are then draped over the vocal fold or glued in place in order to help in restoring the mucosal wave. After this, consideration should be given to any procedure necessary to close any glottic gap by fat injection or implantation or type 1 thyroplasty. The use of pulsed dye laser fibers can greatly improve the precision of the surgical intervention. The laser fibers are used to remove the epithelium from the undersurface of the mucosal bridge and the corresponding area of the vocal fold. And once the raw surfaces on the two sides are clear from any epithelial remnants, without any injury to the vocal ligament itself, then the mucosal bridge remnant, formed by the outer layer of the mucosal bridge and the core of the connective tissue, can be draped or glued to its original site on the vocal fold. As you can see, the preoperative glottic gap has now disappeared after surgery and the mucosal wave was restored. By this, we come to the end of this presentation on the mucosal bridges of the vocal folds. Assalamu alaikum.